Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, Dr. Bert, where we continue our discussion of hip arthroscopy and associated pathologies.
I know for me, one of the hardest things to get used to as I jumped into those cases was the 60-degree scope angle. Just holding it still on the labrum became a challenge. And then much that's even trying to drive around and look where he wants it to go. Now that I've, since mainly doing hips as scope cases, have done a couple of the regular, so like shoulders and knees with other surgeons, I had a hard time adjusting back to 30 degrees. And so what's your take on that? What's your advice for people that are just jumping in to maybe hold a 60-degree still? And as a follow-up, have you found yourself using the 60-degree scope on your other sports cases now?
It's harder because you think about it, you're looking at a sharper angle when you're using it. And so there's not a great way to learn other than just doing multiple cases and building up volume and, practicing on cadavers. If you have the ability to do that, that makes it, I think, a little more helpful. But there's a learning curve to it. It just takes time. And I think that's why, you see this high learning curve where multiple cases to really be proficient at doing hip arthroscopy. And that's why you don't see a lot of doctors doing hip arthroscopy just as a, procedure you do once every couple months. I mean, you really got to be either high volume and commit to this profession, or I wouldn't recommend doing them, because I think it's really it's a steep learning curve. In terms of other procedures, we do use a 70-degree scope. So one of the ones that we do it with is in shoulders. When you're doing a subscapularis repair, it's very hard to see over that front anterior aspect of the shoulder while doing that repair. And I know using a 70-degree scope, you get a little bit better visualization of the subscapularis footprint when you're working. The other situation is in distal clavicle excision arthroscopically. So what's nice is looking up at that posterior superior aspect of the distal clavicle, because I think that's the most common portion that is left when you're doing the distal clavicle excision with a 30-degree scope, because it's just a little bit of a blind spot. So having that 70-degree scope to look up there, I think, makes it a little bit easier. And so those are kind of two applications I use it. And then sometimes when you're doing like glute med repairs arthroscopically, if you're just used to using the 70-degree scope in the hip, you can do it that way. But I know a lot of people switch to the 30-degree scope for that application.
Yeah, I misspoke. I even took 10 degrees off of it, didn't I? Has that become a standard part of your case card for those cases, or are you kind of doing it on a case-by-case basis? You're talking about like the DCE and the subscap.
Yeah, it's on my case card. So I don't do it on all subscaps unless it's a full thickness one and it's hard to see, and you're thinking about doing like a double row or something like that, or you just have trouble getting around looking at it. But typically for DCs, I will switch to the 70-degree scope when I'm doing that, just at the very end. So that makes it, and you'll see, like, you can see the entire AC joint when you do that, and it makes it a lot easier to kind of finish up and make sure you're not missing any of that, resecting any of that bone that's kind of up in that posterior superior aspect.
Final question from me. What advice do you have for PAs that are scrubbing these cases, particularly one that might not do it more than 10 times a year? What's the best advice you can give a first assist?
Yeah, I think, it depends. If you're doing a lot of labor repairs, the biggest thing, what I always tell my PA is that just hold the camera as still as possible. I think it's hard because a lot of times what happens, you'll move a little bit and it's easy to get lost in the hip, and then you're trying to find the spot again. So if you can just hold it steady, don't move the camera and try to find your spot again, because you will lose it. And I think for, if you got to be prepared to do a labor reconstruction, there's a lot of good videos out there on graft preparation. So really be, at least do some research on how to do a graft preparation, because it is a little bit different than ACL grafts. I mean, you get a baseball stitch the graft, learn how to do accordion stitches. They're not that hard, but at least have some knowledge on how to do a graft preparation, because there is first-time surgeries, like primary surgeries that we do, where it's a surprise and you actually have to do a labor reconstruction. So it's nice to have a PA that, if they're not used to scrubbing, in case they, all right, I can do the graft preparation, because that will save the surgeon, 20 minutes if the PA can perform a graft preparation.
Cool. Thanks for that. I should look into Smith & Nephew or Arthrex taking me somewhere and teaching me how to do that.
Yeah, for sure.
Chuck, you might know the answer to this. We do ACL allograft preps at our annual meeting. I wonder if adding this hip allografts might be part of that. And specifically, Dr. Bert, the Beighton score. Can you please spell Beighton for me?
Yeah, it's Beighton.
Oh, thank you. The other follow-up I have, I haven't helped do a hip scope with the capsular shift and the plication, but I did a whole lot of shoulders where we did, capsular shifts and plication for instability.
Mhm.
Is it a similar kind of thought process to stabilize the hip like you're doing for the shoulder? I know it's a totally, kind of apples and oranges, but is it the same kind of thought that you're doing that procedure?
When you're doing the capsular shift from the shoulder, you're trying to tighten up that IGHL, inferior glenohumeral ligament. The only difference with that one is you're taking an anchor, putting it into bone, and then you're tightening up capsule to bone to that glenoid rim. This one, it's purely capsular. So you typically have that femoral-sided aspect of the capsule and then the acetabular-sided aspect of the capsule. So there's a slight difference in terms of technique because you're not really using anchors. You're just using sutures in the capsule. The shift is similar in terms of you go in a medialized direction for the interportal capsulotomy. Then in the longitudinal portion, you're just kind of overlapping a little bit. So you got to think of more of like a mid-capsular shift versus a capsular tightening to bone in the shoulder. So that's the slight difference.
Listeners, stay tuned to next week when we follow up our discussion of hip arthroscopy and pathology with Dr. Bert.
We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.